Perfect. Let me start in the room with Tamsin. She is co-founder and partner at Population Health Partners. As the former director of the UK Office for Life Sciences, she worked with Sir John Bell to write the UK's Life Sciences Industrial Strategy. Her final role in government was in the COVID task force, where she was the senior responsible officer for serology and seroprevalence surveys at the start of the pandemic, and was awarded an OBE for that work. Anuradha Gupta on the screen, thank you so much for joining us remotely, is president of Global Immunisation at the Sabin Vaccine Institute. Formerly, she was deputy CEO of Gavi, the Vaccine Alliance, where she led efforts to put equity and gender at the center of Gavi's programs. Prior to Gavi, Anuradha served as mission director of the National Health Mission of India, where she ran the largest and possibly the most complex public health program in the world, with an annual budget of $3.5 billion US. Thank you so much, both of you, for joining me here today. As you know, the topic is about ensuring equitable access to biotechnology. I think with the experts we have in the room, I'd really like to focus initially on COVID vaccines. We have in the room two people who were really on the front lines of that fight. And Anuradha, can I start with you? Just last week, we heard estimates that if they had been distributed more equitably around the world, maybe 1.3 million lives might have been saved. So the COVAX initiative was meant to fairly distribute these vaccines. Can you tell us what it was like for you trying to implement this vision and maybe some of the lessons learned from it?
Yeah, so thank you, Flora, and good afternoon, everyone. So that's an excellent question. Actually, I lived through the whole experience because Gavi was indeed the hosting the COVAX facility and was responsible for procuring COVID-19 vaccines. Now, what exactly happened? A couple of things. One is that this whole notion that in a global crisis, you can actually come together, and everybody can have the same common motivation of embracing a global goal, right, didn't come true at all. Because what we saw at play was self-interest, very strong self-interest, domestic agendas and domestic priorities. And I think the governments really felt very compelled to first go out, and secure vaccines, to protect their own populations first. And I think that itself just created a major challenge, despite the fact that COVID-19 vaccines were developed, so fast and so rapidly, and actually were also sort of quickly manufactured at scale. So it wasn't really the development of manufacturing that was an issue, but I think it was really just this whole scramble, and so that was the first thing. Now, the second important thing that happened was that clearly countries that had deeper pockets, rushed to over-contract vaccines. And because at that point of time, there was complete lack of clarity on what vaccine candidates would succeed or fail, and people were really acting out of a sense of fear and panic. So that's what happened, that, there was over contracting. There were countries that actually contracted, doses which were 6 times more than their actual need. And that just created an artificial scarcity of the commodity in the market. And clearly, then vaccine manufacturers also prioritize those countries which really had the financial capability and also the political clout, frankly, to sort of ink these deals well in advance. Now, then what happened? And then the third thing that happened was that countries that had vaccine manufacturing on their soil, right, or were or had production of any kind of inputs into vaccine production on their soil, they just absolutely put in place a lot of protectionist measures, right? So export controls, were put in place, and we saw it all over, right? All countries behaved in much the same manner without any exception. And that actually led to a collapse of global supply chains, where the raw materials, ingredients, essential inputs that were required for manufacturing of vaccines just did not flow freely. And then, of course, the vaccines were not allowed to leave the countries where they were actually being manufactured. So I think these were really, this is the backdrop, right? And this is what happened. And at the same, it is interesting, right? COVAX sort of was set up with a very big ambition. So it was a sort of a utopian idea where people believed that it is possible, during a global pandemic, to actually bring everybody together, rich and poor countries alike, and actually sort of have some sort of mutual understanding of how vaccines should be procured and equitably distributed. And that did not happen. So COVAX had 190 plus members signing up as countries are signing up as members. But what happened was, in parallel, countries actually went ahead and had their bilateral deals. And that, I think, just sort of finished COVAX, because COVAX scrambled to get financing in the first place. Financing came very late to COVAX because first, as I said, countries wanted to sort of, make sure that they had already contracted enough vaccine doses. And then the second thing, there were just not enough doses left for poorer countries. So the poorer countries really had to wait painfully long. And then what happened was that COVAX, in my view, sort of was able to supply. Now it has supplied more than 1.5 billion doses, but they came too late, they were too little, and I think it was too chaotic.
Well, thank you so much. Tamsin, let me turn to you. I think that's talking about these kind of, as you said, a utopian, maybe kind of this idea that all these governments come together. But I think on the ground, the vaccines really illustrated to a lot of people, maybe who hadn't thought about it, the combination between industry and government and academia that has to happen to make these the incredible achievement of these vaccines happen. Now, I know that you're very familiar with the Oxford AstraZeneca vaccine. It's something I'm very happy to have in me right now. And you've seen both sides of this kind of equation, having worked in government and now working more in industry. I just wonder if you could tell us a little bit about the successes and maybe the lessons from those interplays between industry and academia and government.
Yeah, okay. Well, it's not often I get to say that there was a really good thing that came out of COVID, because there wasn't that many good things that came out of COVID. But when I was in government, was always really keen to get government and industry to work much better together. And so COVID is just the one shining example, the big example of how industry and government and academia actually all came together and pulled it out the bag. It wasn't perfect, but it just far exceeded anything I've ever done in the past working with industry and government. I mean, government had no solutions. It was like being in the film Contagion, and you looked around and you were like, what are we going to do? And then suddenly, academic groups were coming forward with, well, we have this technology, we think it can scale, it could be used. And then you had industry coming in and saying, well, we have the scalability, we have the pathways, we have the manufacturing, let's come together. And I was sat in these incredible meetings with these incredible companies, scientific companies based in the UK, sort of willing to throw the kitchen sink at trying to get these technologies out to people. And that was just really, it was a great thing. And for all the lessons we can learn from, you gave an amazing summary there of some of the breakdowns that happened with international laws and kind of treaties and agreements. There was a lot of breakdowns, but there was also a lot of coming together with industry and government, and I think that was a really good thing.
And do you think that will be a long-lasting?
No, sadly I don't, and it makes me really sad, because the reason why I don't think it's going to be a long-standing thing is that the intense urgency that COVID gave us made that everybody really rallied behind it, probably at the expense of other things. And that's just not a business as usual, sustainable model. But I do hope that it shows the value of public-private partnerships. And I do hope that it shows that government can be very, if they're very clear and they say what they need and they send out very strong demand signals to industry, that industry can respond in a way, and then government can then respond and honour what it's asked for, and we can see a lot more partnership and cooperation. And maybe that will break down some of these kind of stereotypes of like industry are all money grabbing so-and-sos and government are completely useless so-and-sos. And that will, you know, everybody will learn to work more effectively together.
Oh, that sounds like a good idea. So I know that the three of us separately have spoken a little bit about building on some of those incredible moments, some of maybe the structures that were developed. I think Anuradha, that some of your work you've talked about how maybe the incredibly successful effort globally to vaccinate children has in a way stagnated for some people, and that there are some ideas about how we might identify who who really needs to be reached, what children really need to be reached, possibly leveraging some of these learnings from this huge vaccination effort. So I know that you've come up with the concept of zero-dose children. Can you tell me about this, and how does it help clarify the picture?
Yeah, so, this zero-dose children is a new concept. And I sort of hit on that and pioneered this because of a couple of reasons. Immunization rates have started to stagnate for the last some years in most countries. So we did make good progress, 2000 onwards. Around 2000 also, it was almost the same picture, where whatever vaccines countries had, particularly the low middle income countries, they were unable to expand access to those vaccines. But they were also very constrained in terms of accessing new vaccines, for example, for diseases like pneumonia, diarrhea, that actually kill children, right? And they really are major killers of children. At that point of time, about 1/4 of child deaths were unnecessarily happening because, countries just couldn't access these vaccines. They were just too expensive. So I think in 2000, when Gavi was set up, things started to change, because Gavi model actually started to sort of make sure that poorer countries also had equitable access to some of the newer vaccines. And a lot has been achieved through this initiative. But in 2015, when I joined Gavi, we were extremely concerned about equity in immunization, because we were seeing that as I said, immunization rates were plateauing, and also those populations that were being left behind, but simply not being reached despite all efforts. And really, the third dose of DTP vaccine has historically been the measure, for understanding access to immunization. I remember at that point of time, we really had roughly about 19 million children globally who did not get their third dose of DTP vaccine. And DTP vaccine is the most basic vaccine. So you can be rest assured that if a child has not received the third dose of DTP vaccine, that child would not have received other vaccines as well. But then, I sat down, and when I started to dig deeper and dissect data, I realized that out of these 19 million children who had not received their third dose, actually 14 million had not received their first dose also. And that was a very startling revelation. And then we started to really dig deeper, and we then realized that these children who haven't received even a single vaccine shot actually are representing the starkest societal inequities. And what was shocking was that though only 1 in 8 children was zero dose, right? So you are looking at a very large birth cohort of about 120 million, and out of that you have about 14 million who are zero dose. So 1 in 8 children was not receiving even a single vaccine shot, but they accounted for nearly 50%, half of the vaccine preventable deaths. So this was very obvious that if you don't reach these children, then you can really never bend the curve on child mortality. And then the second thing that I realized was through all this sort of work that actually these 2/3 of these zero dose children live in households that subsist on less than $1.90 a day. And you must, I'm sure all of you know that that's the definition for extreme poverty, right? So clearly 2/3 of these children live in extreme poverty. But then also we discovered that mothers of these children often did not have access to antenatal care, skilled birth attendance, contraception. These households did not have access to sanitation, nutrition, water, hygiene, cleansing agents. So really, in a way, these households were suffering from multiple deprivations and compounded vulnerability. That's how then I started to advocate for prioritizing zero dose children, because by that time the SDGs had come into play. And as you know, the Sustainable Development Goals are actually aiming to leave no one behind. But who's that no one? So really that zero dose child is that no one that you should never leave behind. And if you get into those households and communities, you realize there are other SDGs, whether it's gender equity, whether it is education, whether it is other goals that cannot be achieved. So that's how sort of I started to sort of advocate, and I'm very glad that now zero dose is such a powerful agenda and really at the heart of Immunization Agenda 2030. And most importantly, I think the governments have embraced this. You go to any country, any LMIC, and people are talking today about zero dose children as really the way to improve equity in immunization and prevent deaths of not just children, but also mothers.
Absolutely. I mean, that concept for me, as someone who's just learned about it, it was really an eye-opener. And I'll definitely be thinking about those zero dose children going forward. And Tamsin, I know you've been working on a project with Sir John Bell that's almost, in a way, kind of complementary to that, which is this idea that it's a campaign to think about the life course of vaccines that we might usually associate a life course of vaccines with children, but this is actually, what does that mean for adults? Yeah. So the program is called One Shot.
That's right.
Can you tell me a little bit more about it?
Yeah, sure. I mean, it's kind of at the older end of the spectrum, but I mean, obviously it's not to take away at all from the childhood vaccination campaigns. It just struck us that if you look at, I mean, it was the COVID that kind of started to make us think about it. If you look at the success that we've had with the childhood vaccine campaigns, and I know we've still got some way to go, but we have a universal understanding that children should have access to vaccines. But bizarrely, we don't actually have that for adults. And here we are in this like global pandemic, for a lot of us, the first that we've ever lived through, and every adult needs to be reached with a vaccine. And we're putting in place from scratch these new digital systems and health systems to get to all adults to give them their COVID vaccines. And it suddenly struck us that there are actually a large number of vaccines available for adults that could have significant benefits on morbidity and mortality for adults who are, in the health systems are overwhelmed every winter here in the UK. Every winter in the Department of Health, I used to work on the winter pressures agenda, and we were worried about how many people would need places in hospitals because they would be going in with respiratory viruses. And actually now there are vaccines that could be given, if given systematically, built off the COVID infrastructure that we put in place for digital vaccine registries, and these vaccination centres that now all exist around the country, we could make a material impact on the people who are turning up in hospital with respiratory disease. And I have a lot of personal experience in England, but I believe that would be the case across the world.
Yeah, we're certainly seeing that huge boost in illnesses at the moment.
So am I allowed just to say one more thing?
Yeah, please do. I was going to actually...
I've sort of talked about respiratory vaccines, but that kind of made us thinking about, well, there's this respiratory bundle, RSV, pneumonia, COVID, obviously, flu. But then if you look on the pipeline of wonderful innovations that are coming through, you can see there's the malaria vaccine, which obviously really affects children, but it really affects the more elderly populations as well. And then there's the TB vaccine. So we've got all these vaccines coming down the pipe, and we've spent all of this money and time and effort getting the COVID vaccines and the systems out there for COVID vaccines. I'm not saying that's perfect. There's definitely some way to go, but I would hate to see this infrastructure wither and die, and for us not to use it to reinforce the ability to deliver life course vaccines for all of these diseases which could be prevented. And we could prevent a huge number of deaths if we just leverage something that we've put in place. So
yeah, I mean, we've spent all that money and time. And it's not just necessarily things people traditionally think of as vaccines, is it?
Well, yeah, so we also have this thought that actually you could expand this vaccine delivery infrastructure for long-acting therapies. There's a lot of very exciting long-acting therapies that are now on the market or soon to be on the market for major risk factors. So LDL lowering, so cholesterol, hypertension. There are other diseases as well that can be treated now with long-acting therapies, so HIV prevention, actually schizophrenia. There might be a long-acting asthma for severe asthmatics medicine. So this could be a very efficient healthcare delivery system. And that's what we're really interested in kind of investigating and running some implementation studies to see if we can obviously make a material impact on morbidity and mortality, but also can we do this in a more patient-centric, convenient and cost-efficient way.
And Anuradha, I know that you've looked at these issues, as you mentioned earlier, through a gender lens. And it's, as we were discussing when we first met, HPV vaccine is one of those maybe now that we feel is one of the first that all young adults will start to receive. The question is, are the young adults who can benefit most from it on the receiving end from that global perspective?
Yeah, so this life course vaccination is indeed a challenge, and as was discussed just now, particularly in low middle income countries, and also actually many middle income countries, they haven't gone beyond childhood vaccines. And just for us to be clear that childhood vaccines fall in two buckets. One is where a child receives vaccines and is protected only during childhood. But a child may also receive vaccines which give lifelong protection. So as an adult, for example, hepatitis B would fall in that category, where a child is a recipient of a vaccine, but then it actually makes a huge dent on, say, liver cancer and other liver. So really the benefits are lifelong. So I just wanted to upfront clarify that. But of course, there are going to be newer vaccines where it is not just the children who are the recipients, right? But so also in children, we typically look at at birth vaccination, and we look at 4, 6, 10 weeks sort of thing. So there is a certain schedule, but you don't go beyond that. So for malaria, for example, you are going to look at different time points and different touch points, which immunization programs currently don't have. So coming back to HPV, I think HPV is a vaccine which actually is supposed to be given to girls between 9 to 14 years of age. That is really the target group before girls become sexually active. And we know that cervical cancer deaths are on the rise. Already every year, there are more than 300,000 sort of cervical cancer related deaths of young women. They are in the prime of their youth, typically between, say 19 to 45 years of age. And it is really just a very sad thing with very high social economic costs. So therefore, this HPV vaccine is a highly effective vaccine. And now we have a recommendation from WHO that even one dose of this vaccine can actually give sufficient protection. But what we have seen really, Flora, in most of the LMIC countries is this whole difficulty of actually figuring out how do you reach girls, many of whom now are in schools in these countries, right? And most of these countries do not have school health programs, right? So they struggle to actually, so in the beginning, at the time of the introduction of HPV, they were able to get into the schools and do HPV vaccination in a campaign mode, but it is very hard for them to sustain that effort. But also remember that in these countries, a lot of girls might have dropped out of school before the age of 9 years. So how do you reach those substantial number of girls who actually are not in school? So what you actually require really is a multimodal delivery strategy where girls in schools receive their HPV vaccine, but also girls out of school receive that, and on a very sustainable manner basis. And I think that's where countries have struggled. So what we have seen now really are two things. One is that countries which have 60% of cervical cancer burden globally have not been able to introduce this vaccine so far. So, even introduction of this vaccine remains a very big challenge, partly because women health issues are not receiving due attention in most of the countries, right? And so there is and I think that's a gender issue. That how do we put this whole issue of women health, and if young girls die, because of preventable causes, what does it mean? What are the economic, social costs, and why government should be actually investing in this? So that's one part of the problem. And that's where we are now focused. Even at Sabin, we just want to launch a very big initiative to make sure that we work with governments for more rapid HPV vaccine introductions. But there is a second part of the problem that in countries where HPV vaccine has been rolled out, they are struggling. They're really struggling to find a good strategy. And I think this speaks now to this whole delivery capacity. How do we strengthen health systems and delivery capacities in countries to make sure that adolescent girls can be reached? At some point, these girls might actually want to do boys also, vaccinate boys with HPV vaccine, because that also has public health value. But but also other vaccines, and so there RSV, for example, has just been mentioned. Pneumococcal, for elderly is another. Seasonal flu, COVID-19, but I also feel shingles, for example. And shingles in elderly population can be a very big health issue. So really, and the last reflection that I would want to make is it is important now for us to have this conversation about how do we refocus governments on prevention agenda. Because even in the UK, a lot of people are now saying that probably NHS is really a sickness service. So you're trying to treat sickness once people have become sick. Right? But there are today very effective ways of averting sickness in the first place. And that is the preventive aspect of healthcare. And that's where vaccines play a very big role. So I think just now again, reigniting this whole discussion about public health focus and about focus on prevention is the next big thing in my view.
Well, thinking again and refocusing again on equity, and we've talked a lot about vaccines and long-term health products, but one thing that both of you mentioned to me earlier was the fact that strengthening those delivery systems can have spillover effects, can have benefits to health systems, wider benefits. Tamsin, maybe you can touch on that. In terms of the global perspective capacity building, what kind of positive spillover effects could having that kind of one-shot program in place have?
Well, I mean, there's the obvious one that we keep thinking that if you put these systems in place now, when you're under pressure through like a pandemic or a public health crisis, you've got the systems in place. I mean, the scars I wear on my back were from COVID, were that we didn't have things in place that we should have had in place, and we had to build everything from scratch, which is why we think it's really important with health programs to have this kind of concept of always on. How do you make systems routine now, whether it's surveillance for new pathogens, or whether it's vaccine distribution, or whether it's health checks for individuals, or it's identifying the forgotten citizens that need to be brought into the healthcare system? How can we do that now so that we're not scrabbling around doing that in a pandemic? And I think that's a real kind of spillover of like, it's almost like health insurance, health protection for future pandemics. But I also believe that if you put these sort of systems in place and you're able to grow your health ecosystem, that there are lots of benefits for science and research, and there are lots of benefits, economic growth benefits as well. And I probably would say that, wouldn't I, having run the Office for Life Sciences. But if you want to bring clinical trials to the countries and you want to do new manufacturing, you need the system, you need the whole ecosystem in place.
Absolutely.
So,
and
yeah.
Anuradha, oh no, come back to us. Oh, she's
There
back.
she is.
Okay. I just wanted to bring that out to some of these low and middle income countries where maybe a lack of vaccine manufacturing capacity is one of the reasons why this inequitable distribution happens. So how do you think that some of the structures that were built during the pandemic can help benefit those health systems?
Yeah, so I think what COVID-19 has done is to actually highlight very disturbing inequities in terms of even vaccine production capabilities. I think in the Gavi was one mechanism which was proving to be successful, right? Before COVID-19, and of course because of Gavi, the number of manufacturers has increased because there is a very large volume that Gavi procures every year, more than 500 million. And once we had this consolidation of market and these big volumes, it became more attractive for newer vaccine manufacturers to enter the market, right? So and also Gavi was able to negotiate very attractive, incredibly low prices for some fundamental vaccines. So that's a success story. But I think COVID-19, and there is a report which I would strongly recommend people read that has just come out, which is it is a WHO report on global vaccine market sort of health. And, this actually brings out some very startling things. One thing that it says is that though there are 90 vaccine manufacturers that are approved by WHO, it is actually only 10 vaccine manufacturers who are supplying 70% of the vaccines to countries, this excluding COVID-19 vaccines. So it is hugely concentrated. Vaccine manufacturing is hugely concentrated in the hands of just about 10 manufacturers. Another thing that the report highlights is that for most of the most basic and very essential life-saving vaccines, there are normally only about 2 vaccine manufacturers. So you look at a vaccine like measles, rubella, you look at, pneumococcal, you look at, they are primarily, 2 vaccine manufacturers that the whole world is depending on. And it is not a good, happy situation. And when we look at the regional disparities, then Africa, of course, doesn't have any vaccine very, very little. It has very little vaccine manufacturing capability. So, and Africa, mind you, today has about 1.3 billion people living on the continent. And the projections are that by 2050, this population would double. right? So imagine a continent of 2.5 billion people not having any kind of a capability to produce vaccines for their own people. And it's a sad thing. And because they didn't have this capability, that is why they did not get timely access to COVID-19 vaccines. And I think this, for the first time, was a wake-up call for Africa and for the rest of the world, where Africa started to say, we haven't been treated fairly and equitably. Our people also wanted COVID-19 vaccines, in the beginning, like people anywhere in the world, but they were hugely disappointed. And therefore, they now sort of want or are committed to actually having a vaccine manufacturing capability within Africa. And there's a lot of interest. Now, the point is easier said than done, right? So countries can say, okay, they want their own vaccine manufacturing capability, but vaccine manufacturing is a highly sophisticated operation. And the value chain is quite complex, frankly, from research and development then to manufacturing. And it's not an easy process. And then you require capabilities, first of all, technical capabilities, but then you also require very effective regulation. Because in the absence of effective regulation, you can't produce unsafe vaccines, or vaccines which don't have. So I guess this is the right, Flora, this is just the right direction to go, where absolutely we should make sure, everybody should make sure that we contribute to this whole idea of more distributed manufacturing capacity, across continents, across countries, and really help countries and continents become more self-reliant, because that's the future. And then we won't have the challenges that we saw during this pandemic. We also want to get prepared better for any future pandemic, but a lot of hard work would be required, right? And this would really mean that we turn incentives on their head, because in the beginning, de-risking mechanisms might be required, higher incentives might be required to really kickstart vaccine manufacturing. And given the fiscal strain that a lot of these countries are now facing, I think there will have to be a global compact and global agreement on how we put in place these incentives, so that the whole idea of more distributed vaccine manufacturing actually is realized.
Yeah, and realized with the assurance of quality. Did you have something you want to add to that?
I mean, I really, really agree with that. And we've spent some time thinking about some of those incentives, because I agree with you. I think we need regional distributed manufacturing, and we need that so desperately for vaccine equity, because I totally agree. Like, when you look at people who got to the front of the queue, it was because they had manufacturing, they had a powerful purse, or maybe they'd invented the vaccine, and that helped. And so I can now see why lots of governments across the world are trying to build new manufacturing facilities, but it comes in a complex ecosystem. And I think there are a number of global health players, Gavi, CEPI, WHO, who have a role to play to put in place incentives for standards and regulation. And I think there's a need for organizations like Gavi to be able to procure vaccines from these different regions in a certain way, to have the incentives for the quality of the production line. But this comes back to the kind of one-shot campaign, where we were thinking it's really important to have a sustainable vaccine market, because if you don't have a sustainable vaccine market and you don't have a growing market, then what are all of these factories going to do in really simple terms? So it sounds like I'm a drug pusher, but it's like I think it's very complicated. We need to have sustained demand for vaccines with a distributed network, and achieving that's going to be quite complicated.
Which also ensures that quality is hitting a certain mark, because it's actually being purchased by
because everybody wants
market.
it and needs it. And actually, if we can demonstrate the benefits of life course vaccination, that should grow the market, grow the need for the supply. We've got to make sure it's not concentrated in Europe and North America. We've got to make sure it's distributed across the world, So next time we have a pandemic, everybody has regional supply. I mean, it sounds so simple, but it's going to be fiendishly difficult to do. So,
you know, I have so many more things that I would love to ask you about, but looking at the clock, I had fully intended to have a longer question period because it's such an opportunity for the audience. But so let me just quell my curiosity very slightly, and can I please open it up to the audience? And if my lovely assistant with the microphone, just pause for a moment until you get the microphone so that we can ensure that just everybody can hear you. All right, we have a question here.
Thank you very much. My name is Rachel. I'm a second year PhD in Oxford. Fascinating conversation. I just want to bring it forward to maybe also talk about not necessarily only vaccine, but essential medications that may have a sustained demand across different geographies as well. For example, life-saving medications as simple as insulin, where generics has been available for a very long time, yet very expensive, and similar in the case where production is heavily concentrated in a couple of companies, yet the manufacturing actually might be regional. So one wonders, what's the interplay between government sort of procurement and sort of the manufacturing regional capacity and interplay with the corporates who gets to decide on the money, pricing strategies, how can we get these essential medication that's been existing for a very long time to those who are in need. We talked about African continent that has a growing population, and I suppose there's a huge need there as well. Thank you very much.
Yeah, that's such an excellent point. I don't know, Tamsin, I saw you nodding.
Yeah, I mean, I'm nodding, but I'm not sure I have the perfect answer for that. I would separate it from sort of the ideas that I've been putting forward around vaccine delivery. I'm not negating the need for essential medicines at all, but something that you said that really resonates with me and that we spent a lot of time looking at when I was in government was around the pricing kind of dynamics. And I feel that there are new procurement models needed for essential medicines in a big, big way, and we need to see new commercial flexibilities. I have seen some really good examples, like with AMR and subscription models. When I was in government, I've seen population health deals where we've gone after what is the population that needs to be treated and how can we make that affordable through new commercial arrangements. It sounds like a very boring topic, but procurement, I think, is so important. And I actually think that COVAX is a really good example of procurement power. And I understand that some of its limitations in COVID, but I've got a lot of respect for it. And I think that in the future, I need more COVAX, not less COVAX. And so maybe you've got some answers on what we can do with insulin, but I do think we need new commercial models.
Anuradha, did you want to speak to that?
Yeah, so I really think, in health, it is a question of really whether you are going to allow the free market, dynamics to operate, or you really want stronger intervention of the government in some cases, particularly for the most essential life-saving drugs, which include vaccines, right? And a lot of, so you have a lot of more, there's no one size fits all approach here, right? Because as I said, capacities in different countries to actually invest in health also vary considerably. So, in richer countries, governments can actually, they actually spend billions and billions of dollars, right? And there the question then is not really about how much money, but about what kind of policies can make the use of that money more efficient and smart, and also pro-poor. Because there are people, who are given the, high per capita income in advanced economies where they can afford, right? And the insurance models. But we know that in most of these countries now, you have a growing size of poor population that is actually struggling, right? So what I really think that's a pro-poor, pro-equity policy environment is something that even the most advanced economies will have to look at, right? But then the second part of the world is those lower middle income countries where actually historically spend on public health or public financing for health has been extremely low. It has been abysmally low. Even in a country like India, 1.8% of GDP is hardly any investment in the. So therefore, in most of these countries, you would see that and there is no health insurance, universal health insurance, right? Or universal health coverage. So what happens is that people in the end have very high out-of-pocket expenditures, right? So if you can afford that, then you can save your life. If you don't have money in your pocket, then you lose your life. And that is why I was alluding to zero-dose children, because when they get these infectious diseases, first they are at a higher risk of getting infectious diseases. But if they get an infectious disease like pneumonia, diarrhea, that they can, if they were to access healthcare in time, the lives of these children can be saved. But they're unable to access that healthcare, right? Because they just don't have the financial bandwidth. And you know that millions of people suffer from medical impoverishment every year because of catastrophic medical expenditures. So to me, the whole issue is about this, that what is the level of public financing, right, for health in different countries, depending on what trajectory they are at. And then second is within the overall investment that governments are making, what are the kind of policies, right? For because what we need to ensure in the end is that people who can pay for their medication should pay, and people who cannot pay, absolutely the state must intervene in order to make sure that something as basic as insulin or oxygen, or you would be shocked, but I worked in India, and something as simple as oxytocin or Lexalf, right, which can actually save lives of women when they give birth to a child, were not available. Very, very sort of cheap drugs, because probably the poorest of the poor people could not even afford that. And, the government did not have sort of enough, I would say, sort of, sensitivity to make sure that some of these drugs are actually provided free of charge. And of course, that started to change. And when I was there, we made a lot of sort of new policy interventions. But I just want to therefore say that, yes, we need to ensure that there is universal access to essential drugs, right? But the solution is going to vary from country to country.
Thank you so much. Great question. I think I see a hand over there in the back.
Hello.
Hello.
I'm Sakina. I just started DPhil biochemistry. My question is for students who are just 22, we're just starting out, how can we contribute to improving this access? Because we're talking about changes at the government level or institutions or policies in place, but what can we do at our own ways to improve access?
Yeah, I love that question. That's one that's on my list as well. What advice would you give to early career researchers and policy analysts and academics and healthcare workers who are interested in tackling these problems? Maybe Anuradha, do you want to start this time?
So my advice always is that for those young professionals who are beginning their journey in this complex world of public health, you should always tell yourself that you have an opportunity. You have a rare opportunity to make a difference, right? And to save lives. And you must absolutely seize it with both hands. And then the second is make compassion your guiding principle. Because there are people, a society is not homogeneous, right? You don't have, everybody is not at the same level. You always have poor people who are downtrodden, who are suffering from vulnerabilities and deprivations. And I think you should always keep them at the center of your work, right? Saying that, okay, whatever research I'm doing, how's that going to help that person who doesn't have access to insulin today? This is what I do all the time, right? Whenever I take a decision or whenever I'm thinking about something, I'm saying, okay, how is this policy or how is my action really going to create a positive, powerful impact for that person who is today suffering for want of things that actually should be a basic fundamental right.
And Tamsin, I know we've talked quite a bit about your switch from government to to industry. Does that inform what advice you might give to a person in their early career?
Of course I agree, like always do what you think is right, and you know, like this systems need change. So if you see that it needs change, it probably does, and go for it. But what I wanted to say was that sort of it's acutely obvious to me, the older I get, that the ideas come from a lot of like university students, and all of the technology that I've seen used has actually come from universities. And so you hold the key to the solutions, and that's a really exciting thing. And there's lots of, I mean, government is really an enabler of that. Industry, big industry, is the scaler of all these ideas, but you hold the ideas to the solutions, and that's very exciting. And so just go for it. And I can't wait to see all the ideas that are going to come out.
So yeah, it sounds like the advice, it might seem when you're starting out that you can't do much, but it sounds like the experts say that you definitely can. I think we might have time for one more question. Does anyone have a hand? Oh, we got the first at the front.
Hi, thanks so much for a fabulous discussion. My name's Marston. I'm a DPhil student in science and religion. I do bioinformatics and theological ethics. So one of the things I discovered during the early stages in the pandemic was that people of certain religious sentimentalities in the US were very aversive to taking the COVID vaccine, and whether or not they had access to this technology because of infrastructure was to a certain extent irrelevant. And we see that in developing nations across the globe as well, whereas those, as sad as it is, and as much as a travesty as it is, as that young girls are being pulled out of education, it's likely that they might have other influencing factors that would lead them to not take these vaccines in the first place. So how are we to pair necessary education and social empowerment such that when these vaccines and technologies are physically available, we will actually have people who are prepared to accept this?
I mean, yeah, what a pertinent question. Anuradha, I would love for you to address
Yeah.
this with your perspective.
Well, wonderful question, because I was wondering that during this discussion, we haven't focused enough on demand, right? And thank you for raising this question. I really think this is at the heart of the problem. So this is 50% of the problem. 50% is supply side, right? Where you work on new technologies, and you then manufacture at scale, and you distribute equitably. But then 50% of really the remaining challenge relates to community demand. So we call it community acceptance and demand, right? And based on my experience, what I have seen is that trust, community trust in public health institutions, in governments, really plays a very big role here. Particularly during COVID-19 pandemic, you saw that people actually lost that trust. That trust was weakened, right, in many places. And because there were conflicting messages that were coming, people had a lot of questions on their mind, and they wanted information, and that information was not coming. Research and, several effectiveness studies have lagged. So there's always a lag. But in the meantime, the answers were not being given to people. For example, even pregnant women. In the beginning, I know that when COVID-19 vaccines were being rolled out, a lot of pregnant women asked, whether it is safe for them to take COVID-19 vaccine. What would it do to their pregnancy? A lot of young girls had this question of whether it's going to impact their fertility or their menstrual cycles in any manner. And that information was not forthcoming. A lot of people now had questioned when there were mutations and there were newer strains, whether, the suite of vaccines that were being offered to people, whether they are going to work against, the newer strains. Because every day there were reports out saying, they escape the immunity provided by vaccines or even natural infection. And then people said, should they go in for, and that, but I think we all struggled to furnish that information in a credible manner, in a timely manner to people. And that really erodes trust, frankly. And that then we create a climate where misinformation and rumors will abound. So I really think in a pandemic situation where, technologies are being accelerated, people have doubts about the safety and efficacy and whether all the standard protocols have been, met or not. And then there are newer inquiries. I think we absolutely have to pay attention to making sure that we listen to communities, we listen to their concerns, we listen to their questions, and actually really organize ourselves to respond to them in a highly authentic and credible manner. So on routine immunization, we have seen the same thing. So you raised this whole issue, the indigenous populations within US, in Australia, in UK, everywhere, right? Ethnic minorities, indigenous populations do not come forward to take vaccines when they are actually being offered. Services are available because they have questions, they have doubts. They don't have trust in the intention or in the positive intent of their governments and public health institutions. And I think that's something that we have to absolutely. So at Sabin, actually, we are doing some cutting edge work in this and trying to understand social and behavioral sort of drivers of comments. So really bringing a science lens, social and behavioral science lens to some of these questions, because they have not received due attention in the past. And as we move forward and as the number of vaccines actually increases and also we get into life course vaccination, this is going to become a very important aspect to address.
Mm-hmm. Tamsin, did you have
I just
something?
add briefly, also from my perspective, is that we do a very good job of collecting data in the wrong places, and we don't have locally collected data for those communities that it was evidence from my patch that these vaccines work, and it's not just vaccines. That comes back to the earlier thing that we were saying around the infrastructure. I mean, if you don't have the research infrastructure in that particular community or area or region, then it's very difficult to collect that data. And, as a policy maker, evidence-based policy is really important. It's really important to make the policy decisions, but it's also really important for communications. And I know that we didn't have that in the last pandemic, and it would be great if we could put the structures in now so that next time round we do have better data, localized data that can be used.
Thank you so much. Such a great question to round things off today. I'm sorry that we can't take more. Thank you so much to the panelists today. Such a fascinating topic. Please let me thank you to the audience as well for being here.